So I just want to applaud Dr. Shatsky again for that tour de force. That was really impressive. You covered so much ground. I'm not nearly that ambitious. So I decided for this segment really to focus in on an area that doesn't get too much airtime amongst the oncology community, but there have been some big groundbreaking developments in the last year, and that's non-metastatic prostate cancer. And so today's talk, we're going to sort of define the treatment paradigm for non-metastatic prostate cancer, go through some updates to management of M0 CRPC with a PSA doubling time of less than 10 months, review historical landscapes of biochemical recurrence, discuss updates to the management of high-risk biochemical recurrence with ARPIs, which are androgen receptor pathway inhibitors, and end on some future directions for non-metastatic prostate cancer. So I really like this schematic a lot. It's something I use in the clinic a bunch when I'm talking to patients, just about sort of the biologic evolution of prostate cancer. Most patients, as we all know, they're treated locally, or they're treated for local disease with definitive therapy with either radiation or surgery. Unfortunately, about 20 to 50% of patients after local therapy go on to develop rising PSA. And generally in that scenario, if they've gotten surgery, they go on to salvage radiotherapy with or without hormone therapy. And then if they've gotten definitive radiation, they then get some sort of hormonally driven therapy. So the talk today is going to kind of go in reverse order. So we're going to start with a discussion of M0 CRPC, or non-metastatic castration-resistant prostate cancer, and dovetail back into a discussion of biochemically recurrent disease. So as you can see here, metastasis-free survival is not a one-cut kind of defines all disease. So it's, you can see it really depends on patients' Gleason score and PSA doubling time. And we've known this for quite some time. This is some data that Emmanuel Antonarakis presented 12 years ago now that looked at patients based upon their Gleason score and doubling time, and it really marches out nicely. And higher Gleason score, the risk of MFS goes up, as well with shorter doubling times, as you can see on the right here. And so that sort of brought about this idea of moving ARPIs up in the treatment armamentarium for patients with M0 CRPC with a short doubling time. In 2019, 2018, there were 3 kind of seminal trials, all of which looked at different applications of an ARPI in this context. So darolutamide was ARAMIS, enzalutamide in PROSPER, and finally we had apalutamide for Spartan, all of them kind of having similar outcomes. So we saw a really substantial improvement in metastasis-free survival. And why MFS is important is it's a well-validated endpoint in patients for overall survival in patients with prostate cancer. And so this is what led to NCCN's approval for all 3 of these agents, specifically in the context of less than 10 months doubling time. And as many know, it's this now a standard of care that's been in place for many years. There was some updated data presented this past year at ASCO GU, looking at real-world data across these 3 agents to try and discern which of these 3 offers possibly better outcomes for our patients. So this DEER study was a retrospective observational chart review using Precision Point Specialty Network of urology practices. And so looking at patients from 2019 to 2022, what they saw was it appears as though darolutamide offers a slightly better advantage compared to enzalutamide or apalutamide. So you can see that the patients with a metastatic event within 6 months was 15% with Dara, 28 or so with Enza, 23 with APA, and it sort of continues down that trend in the chart on the right there. And similarly, we saw in that same study, there were fewer M0 CRPC patients treated with darolutamide who ultimately discontinued due to metastasis, and fewer adverse events as well. So that top graph chart on that says AEs there, you can see that there's fewer adverse events in the darolutamide arm. So suggesting that when trying to choose between these three, I personally, in my practice, go with darolutamide for these patients. So back to our chart here, we're going to dive back into biochemically recurrent disease. So what is biochemical recurrence? There's two definitions. If you've received radiation, the Phoenix criteria was established in 2006, which essentially stated that you need to have a PSA of greater than 2.0 above your post-radiation nadir. So in other words, if you get definitive radiation, not uncommonly, we see a little bit of residual PSA afterwards. So if you nadir at 0.5, then you need to get up to a 2.5 threshold to treat that as biochemically recurrent disease. And the rationale there is that you're leaving some native tissue in place, so you're not removing the gland altogether like you do with surgery. So it's permissible to allow a little bit of PSA when we're doing surveillance testing these patients. In contrast, after surgery, you should have an undetectable PSA. And so if you have any sort of detection on two or more determinations of a PSA greater than 0.1, you meet the definition of biochemical recurrence. So there's been several very large cooperative group studies looking at how to best pair hormonal therapies with or without salvage radiation. So RTOG 0534 or S-Sport was one of those that determined there was a PFS benefit in patients who got the addition of 6 months of radiation, 6 months of hormonal therapy to radiation with a hazard ratio of 0.5, GETAG AFU 16, very similar results, so 0.54. Radicals HD, in which 71% of patients were salvaged, very similar outcomes. So you see a very consistent trend across studies here, but I just want to bring everyone's attention to the endpoint here. So we're talking about a number, and a number that doesn't always correspond to real outcomes for our patients. And so when we think about MFS, that endpoint that's a lot more validated for overall survival, results were a bit more mixed. So you can see that GETAG AFU was significant, but S-Sport not so much, and Radicals was quite off for overall survival. So then other studies started to ask the question, well, maybe we should try longer than 6 months. RTOG 9601 thought about what about 2 years with bicalutamide, and found that patients with a higher PSA at starting, in that subgroup, there was a survival advantage. So possibly longer is better. Similarly, Radicals HD, which was presented at ESMO in 2022, found a 6% absolute benefit in 2 years compared to 6 months. So that comes sort of when you look at the other side of the coin, that it's important not to overtreat these patients because, as we know, ADT is not a very benign treatment. It comes with a whole host of side effects. In patients receiving that treatment, it's going to be things like hot flashes, fatigue, erectile dysfunction, decreased libido, problems with high blood pressure, et cetera. So a lot of decreased quality of life while they're living in a low testosterone state. Long-term effects of cardiovascular complications and skeletal events also start to emerge as we prolong our treatment. So several studies have looked at intermittent versus continuous, and across the board, they sort of come to the same conclusion that there's no benefit to continuous ADT. So there is a case to be made that we should not be over-treating patients. And so then we're kind of in this middle zone here. How do we select the right patient for the right duration? We have these great numerical outcomes, but they come at the expense of several of these symptoms that we just discussed. So, 2 studies that were published, both of them like within the last 6 months, tried to see if taking that same approach that we talked about from M0 CRPC and applying it to a higher risk subgroup within the biochemically recurrent space, might offer a therapeutic advantage for these higher risk patients. So PRESTO, which just came out in JCO, looked at in the post-surgery setting biochemical recurrence with that greater than 0.5 PSA, as we know from our TOG 9601, higher response rates, as well as the doubling time of less than 9 months. If the addition of apalutamide or apalutamide plus abiraterone to ADT offered any sort of advantage. So those all therapies were given for 1 year, and the endpoint was called PSA progression-free survival, which was nadir plus 2 or greater than 2 following treatment confirmed on repeat measurement. And so this is a breakdown of the patient characteristics. You can see they're all pretty much equally distributed arms here, and not really too much more to discuss here, just that all arms were balanced. So looking at the primary endpoint, it did meet its primary endpoint. In cohort B versus A, we saw a median PFS of 25 months compared to 20 months in the apalutamide plus ADT arm compared to ADT alone. And it seems to be based upon the curves that this is a sustained benefit. And similarly, there was a benefit here when adding a second ARPI, but what was quite striking about the addition of the second ARPI is there was not really an additive benefit. So we see a slightly better improvement to 26 months, more or less, compared to 20 months. Again, statistically significant compared to ADT alone, but not so much of an additive benefit compared to the 25 months with one agent. So some of the more common side effects, nothing really surprising here. Some of the more typical side effects that we might see within these agents. So for example, third from the bottom, rash. We're not too surprised to see that apalutamide, patients who received apalutamide had higher rates of rash. That's a consistent toxicity. Hyperglycemia was higher in patients getting the abiraterone due to the prednisone you need to take with it. So not surprisingly as well, you know, when you're only giving ADT, you're going to have less incidence of the hormonal side effects of vasomotor symptoms and fatigue, et cetera, but not dramatically so. So grade 1, 2 for the arm B, you can see it's in the 70s, and for hot flashes, for example, and pretty consistent with ADT alone. So toxicity-wise, not too much worse with the doublet compared to monotherapy. And so in conclusion, you know, PRESTO showed us that following surgery, if a patient has a PSA greater than or equal to 0.5 and a fast doubling time of less than 9 months, apalutamide plus ADT improved PSA PFS compared to ADT alone. Unfortunately, there's no data, though, on metastasis-free survival or overall survival. So we're hopefully going to be seeing those down the road from that study. Another big takeaway was that adding a second ARPI, something that was quite novel for this study, it was better than ADT alone, which was the study design. But when looking between cohorts B and C, not much of an additive benefit was seen with that second ARPI. And then there were no new safety signals, and the addition of one ARPI is beneficial in this patient population. Still a little early for FDA to weigh in, but I expect that this will be something available to our patients later this year. The other big trial I wanted to touch on, this was EMBARK. EMBARK was a seminal paper, came out last year in New England Journal. Similar study in the sense that it's high risk biochemical recurrence, but a slightly different patient population. So in EMBARK, patients had to have a PSA of greater than 1 instead of 0.5. And after radiation, they needed to be above that 2.0, above the post-radiation nadir. Similar doubling time of less than 9 months. And then as well, there was stratification built in based on the different rates of PSA doubling. And this was a 3-arm trial. There was Lupron plus placebo compared to enzalutamide plus Lupron versus, for the first time, just enzalutamide monotherapy, which was kind of a novel component to this study. Treatment for this, instead of 52 weeks, it was given for 9 months, and there was a check at that point to look to see if PSA had become undetectable, and if it was, patients went on to a treatment holiday. If not, they remained on treatment. Primary endpoint was metastasis-free survival, with key secondary endpoints for PSA progression and first neoplastic agent overall survival. Patient characteristics here. There's a couple I just want to touch on in particular. So doubling time was quite fast. So these are patients where the PSA is doubling in the 5 months or less ballpark, meaning that their disease biology is quite rapid. And then the other thing that was quite striking about EMBARK is that it was a bit, even though distributed well between all three arms, they allowed for patients who got just radiation alone, surgery alone, or radiation or surgery followed by radiation. So really encompassing a pretty broad bandwidth of our prostate cancer patient population in the biochemically recurrent space. And so the primary endpoint was reported out here. As you can see, at 3 years, the MFS in the patients who got the ENZA combination was about 93% compared to 83% or so with the Lupron arm. 5 years was 87 compared to 71%. And so pretty substantially improved with the doublet compared to Lupron alone, hazard ratio 0.42. Looking at subgroups, there was more of a efficacious treatment kind of across the board. You can see in the PSA doubling time breakdown, there was more of a robust benefit in patients with 6 months or less. The 6 to 9 monthers were not statistically significant, although there was a trend. And then it was kind of, I can't really explain it too well, but there was a more impactful response in Europe and the rest of the world compared to North America. Interim OS was also found to be statistically significant. And so that was a big sort of blockbuster headline with this study. First time we saw OS in the biochemically recurrent space as a key secondary endpoint, hazard ratio of 0.59. This is that third cohort, the enzalutamide monotherapy, compared to ADT alone. Also met the primary pre-specified endpoint of metastasis-free survival with a hazard ratio of 0.63. So not as robust as using Enza plus Lupron, but still appears to be better than Lupron by itself. So looking a little deeper at these secondary endpoints, the chart on the left is showing us how many of these patients got to that sort of crossroads at the 36-week mark where they were undetectable. And so it kind of marches out nicely here with the highest proportion of those being in the doublet arm at 91%, followed by Enza monotherapy 86%, and only about 2/3 in the ADT alone arm. And then as far as duration of treatment suspension, it was quite interesting that there is a more durable response in the Lupron arm compared to the enzalutamide monotherapy arm, 16 to 11 months, suggesting that adding in that Lupron component does get you some additional time off therapy. Looking at patient-reported outcomes, I think this is where we start to get into the nuances of how to select which treatments for which patients. So what you see here in the top is the Enza combination versus Lupron. On the bottom is the Enza monotherapy versus Lupron. And so overall, not statistically significant as far as quality of life per FACT-P or item 3. So trends certainly in favor of ADT alone, but nothing significant popping out. However, when we go into the subdomains of FACT-P, what we see is that in the Enza monotherapy arm at the bottom, there appears to be a little bit more of a toxicity signal in the cancer subscale score and the advanced prostate cancer index score compared to the doublet therapy. As far as the QLQ PR25 analysis, though, you can see here that the sexual activity subset in the enza monotherapy on the bottom graph was actually in favor of enza monotherapy. So as a patient who may be someone more better suited for enza monotherapy in this context, maybe someone who's very sexually active, worried about the sexual side effects of the hormonal therapies, you know, might be something more aligned with their priorities to go with an enza monotherapy approach. Safety-wise, overall, well-balanced. I did just want to call everyone's attention here when looking at the adverse events to dose reduction or permanent discontinuation. You can see in the enza monotherapy arm to the far right here, it's about 34% or so all grades that led to dose reduction or permanent discontinuation. And that's quite a bit more than when we look at the enza combo therapy or the Lupron monotherapy at 27 and 14%. And so when trying to figure out why that may be, a few things kind of popped out to me when looking at the treatment-related adverse events. So in the enza monotherapy arm, 45% of patients went on to develop gynecomastia, with another 15% developing nipple pain. So it's something I really do counsel patients about when talking about the enza monotherapy arm. If you're going with this choice of agent due to sexual side effects possibly to being more tolerable, it comes at this pretty substantial increased risk for gynecomastia and nipple pain, gynecomastia being one of the few side effects that we see that can be irreversible. There's treatments like low-dose radiation that can help from time to time, but it's definitely a serious consideration for patients when I see them. Hot flashes, though, as you can see, also substantially less in the enza monotherapy arm, so something else to keep in mind. And then of special interest, the big takeaway here was that the most common adverse events were fatigue, fall, fracture, hypertension, and musculoskeletal events. Not anything that was surprising, and they were more or less pretty balanced across the arms with a little bit of a higher incidence when given with enza combination. So the conclusions here of EMBARK is that in patients with high-risk biochemical recurrence, which again was PSA of greater than or equal to 1, after surgery or greater than or equal to 2, after primary radiation nadir, as well as a doubling time of less than or equal to 9 months, enza plus ADT improves MFS compared to ADT. And there was additionally a trend towards overall survival at the interim analysis with a hazard ratio of 0.59. Still waiting on final results, though. Enza monotherapy also led to an improvement in MFS compared to ADT. These results, though, were tempered by higher rates of gynecomastia and nipple pain. Neither enza combo nor enza monotherapy negatively affected quality of life or showed new safety signals. And based upon the findings from the study, there's FDA approval for both enza combo therapy as well as enza monotherapy for our patients with biochemically recurrent high-risk prostate cancer, which is a really exciting development because these patients are the ones that do carry the worst risk of progressing to metastatic disease. So I'm just going to I know I'm kind of running tight on time here. I'm just going to quickly touch on PSMA PET CTs. I know, it's become very commonplace at this point to incorporate PSMA PET CT in this context where you're looking for very, very low levels of disease and what may be contributing to this biochemical recurrence. The Condor study 2021 showed us that it is a superior modality compared to conventional imaging. So something that we at City of Hope use very regularly and as well in the community. So ARISTEP is a study that's ongoing, looking to ask the question in this high-risk biochemically recurrent group in which we're catching them with PSMA positive disease prior to progressing to true metastatic disease on conventional imaging being CT and bone scan, is giving a escalated approach with apalutamide for 2 years going to be better than placebo plus ADT for 2 years. So it's building upon the EMBARK and previous studies in the escalated 6-month duration to 9 month or 9 month to 1 year. Does 2 years offer additional benefit? And so these results will be forthcoming in probably 2025. So just to wrap up here, patients with M0 CRPC, doubling time of less than 10 months, should be considered for ARPI as standard of care. Patients receiving salvage therapy can also receive concomitant ADT for 4 to 6 months, particularly if a PSA value is greater than 0.5. For patients for whom their doubling time is less than 9 months with a PSA of greater than 0.5, 2 ARPIs are not better than 1 with the addition of Lupron. And then for patients with doubling time less than 9 months, PSA greater than 1 or greater than 2 above radiation nadir, you should consider escalation with ADT plus enzalutamide as a new standard of care per EMBARK. And lastly, the PSMA PET CT and how that fits into the whole treatment workup is going to hopefully be clarified by ARISTEP.